Today's webinar is going to build off the last one that we did, where we were more focused on, how the heck do I turn the spotlight thing off? I'm sorry, I'm just trying. I turned the spotlight on by mistake and it messed my cursor up. I'm trying to figure out how to turn that off. Just a sec. Ron, I think I turned this on by mistake. Oh, fixed it. Fixed it, just took a couple tries. So I'm back. Sorry, that was like the most unusual IT issue I've ever had. Today we're going to talk about managing high ED utilizing patients. This is going to build off that last webinar, the last discussion where we had, where we started to introduce kind of high risk, but when we did our high risk, we called it red patients. So the idea of the red patients is really going to be, these are the patients that we kind of need to take a second look at. So as much as possible, when we're thinking about high ED utilizing patients, it's really going to be, all right, we've identified a group of these higher risk patients, and this higher risk patients that we've identified, they have high ED utilization. So if we're going to attack kind of part of, or focus on part of that grouping of high risk patients, how do we focus on a segment that we feel like we can influence? And that segment is the patients that are using the ED quite a bit. So today we're going to do a review of kind of those high-risk discussions, those earlier things that we talked about. Talk about the role of the emergency department in the care setting. We're going to start to identify high utilizers, or figure out how we're going to identify those high utilizers. One of my favorite parts is the idea of a what versus a why. We're going to talk about care options, how we should be supporting some of those higher ED utilizing patients, and then do a quick review of the Care Direct platform, which would be one way to pull up some of those lists for yourself. So at our July webinar, we talked about identifying specific patients, and then from identifying those patients, we talked about using transitional care management, doing a few more clinic visits for those higher risk patients, maybe introducing chronic care management, or those disease-specific coordination activities, like maybe a diabetic management program. And those are specific programs that you could try and do. And again, we're not going to spend as much time on chronic care management or transitional care management today. If you want more information on those, you're welcome to review those earlier slides. But it's really designed around 5% of our patients account for about 37% of the ACO's expenditures, and about 10% of those attributed patients account for about 55% of our total spend. So knowing that this small group of patients has a huge impact on our costs, how do we make sure that we're focusing our efforts on those small group of patients as much as possible? And when we had talked about identifying those high-risk patients, we talked about high cost or high HCC score, maybe patients with risky conditions, or those that are utilizing services differently than their peers. And for today, we're just going to spend time focusing on those high ED utilizers, feeling like that's a group that we maybe can influence in a different way to hopefully drive better outcomes for the patient as well as savings for the ACO. So today's topic, I would say, is really important and relevant because the U.S. spends about $60 billion a year on ED care. Now that's 2% of the total expenditure. So when I was doing some research for today's webinar, I'd see an article by the Annals of Emergency Department Medicine where they would talk about it's actually a small portion of the total spend. Well, it might be a small portion, but it's still $60 million. An emergency department is often the kind of gateway for more expensive care that a patient is likely to receive. Other needle sticks, other prodding, as much as possible, we want to think about how can we make sure that those ED visits, those ED services, they're only kind of for when the patient most needs it. For instance, we had 106 patients that are attributed to UPQC, so 106 out of 8,500 that had 6 or more ER visits. We had a handful that actually had 20, 25, 30 or more ER visits, for reasons that didn't necessarily seem to make sense either. So today we're really thinking about those patients that just keep going to the ED a lot, how can we influence them in a positive way? So as we're talking about ED use today, almost kind of like a ground or like a level setting for the group, I'm going to approach today as almost kind of agnostic in a way of, I'm going to say that every emergency department does a great job. I'm going to say that every clinic or every urgent care clinic provides high quality care. Emergency departments, as we know, are subject to those EMTALA regulations where they're required to see patients if they're in an emergent situation, or at the very least do a triage for them. We know that an emergency department is an incredible resource. Meaning with that emergency department service, we know that they are going to provide some of the highest quality care that you might get anywhere, or some of the most sophisticated care you might be able to see anywhere. It can be difficult to understand. It might be difficult to understand the true meaning of why a patient uses some of the services. And a patient, most of the time, is going to seek out the care that they think is best. So knowing kind of those 6 basic sort of clarifications or caveats for the group, how do we sort of attack this, knowing that there's that 106 patients that use the ED more frequently than others, but also probably some patients that maybe used it 3, 4, 5 times that just don't seem to quite make sense. So as a kind of outpatient perspective, or almost an outsider's perspective, the reasons why I would promote avoiding unnecessary ED use is it doesn't always help care coordination as much as we'd like to think. When you go to the ED, it's often that very intense acute care episode. Or sometimes the providers get in the mindset of treating every patient as though they're in that acute episode. Meaning that if you come in for an issue related to your diabetes, it's going to be treated with a similar mindset to somebody that's treating chest pain. And that's different than that clinic visit where you're more focused on chronic conditions, things that we need to make sure we're helping the patient with for the lifetime. Now, the idea of cost and value are so important for us as an ACO, or just in general as we're thinking about being good stewards of the Medicare resources. High cost doesn't necessarily mean improved outcomes. We know that because Americans spend more money on healthcare, but don't necessarily have the kind of health outcomes that we would always like. I would say more trips to the ED is going to result in more imaging, more needle sticks, and more kind of unnecessary or at times unpredictable wait times. We know that oftentimes we'll drive past a billboard that says 0-minute wait, 10-minute wait, 3-minute wait. That's not always the case because of different levels of triage that occur. We need to make sure that we're educating our patients on all of those components, because those are going to play a big role in helping to make sure that our patients get the care they need when they need it. So one of the first things we always want to pay attention to is, how do we identify these patients? So part of it is going to be, because of the ACO, we have access to a lot of extra resources. Care Direct, which is that digital platform that we have available to you that makes it easy to pull lists of your patients that went to the ED, lists of your patients that are maybe a little bit higher cost, list of your patients that are due for a transitional care management visit or need an annual wellness visit. ACO Health Solutions can also provide that really neat claims-based information. And then I always love to give a special plug to Lori, because I think some of the things that happen with the state health exchange that you have are really cool. And we were in a meeting last week with the other Imperium team members, and we were talking about health exchanges, and I said, I know that Utah's got a pretty good one. And a big part of that is I can really credit Lori for making sure that the right groups have the right information when their patients are discharged from the hospital. Now, you can also think about identifying those high ED utilizers using the information that you would have already had. Maybe using the clinic medical record visits where you're getting those discharge notifications already, keeping those documented in the patient's visit. Maybe as part of a annual wellness visit where you remind the patient or ask the patient when was the last time they went to the emergency department. Or those transitional care management visits where you're seeing the patient after they're discharged from an inpatient facility. And by seeing the patient when they're discharged from an inpatient facility, it allows that extra opportunity for coaching, education, to make sure that the patient gets the care that they need. So when we think about emergency department care, now this was one of the things that when I was thinking about emergency department care, I had at times a tough time with, because there's a number of misperceptions that occur related to ED use. I'm saying that as somebody that used to work in a hospital, somebody that really benefited my departments as couple outpatient lab and imaging department, we benefited from more ED visits. Hospital leadership is going to count every day the number of ED visits that come in. But one of the misperceptions is that the care team is better. That's not always necessarily true. You might have just as good, if not a better nurse working in an urgent care, just as good, if not a better provider working in an urgent care clinic than you might find it in an emergency department. There's often that patient perception of like, well, they'll have all those extra services in case I need it. Just because they have it doesn't mean it's going to be used appropriately. Sometimes a patient is more likely to end up on a CT table than they need to be. Sometimes, and that's going to result in increased exposure to radiation. They're going to get extra needle sticks, extra kind of pokes, testing, prodding, as a way to just kind of figure out what's going on, because that every provider is going to, or every visit can be treated as that acute, very intense interaction. Emergency departments will often brag about their very short wait times. That very short wait time sometimes is true, but because of the triaging, a patient that comes in for a less major or less acute illness may have a longer wait time than they would if they went to a traditional or a walk-in clinic. Oftentimes a patient feels like, well, it's the only place I can go without an appointment. That's not true. Again, many clinics are able to take walk-ins, as well as those urgent care clinics or after-hours clinics that can be available. So unfortunately, a lot of people feel like if I go to the emergency department, I'm not going to have to pay. Now, I will tell you from personal experience, emergency departments are getting more and more to the point where they're expecting co-payments from their patients on every visit or every appointment. They're starting to expect those co-payments. So having to remind our patients that you're going to have to pay when you go to the ED as well is a big deal. Oftentimes urgent care is more available than we sometimes realize. Now I know in Vernal there may not be after hours care at all times of the day, but there is often more urgent care than we're sometimes willing to admit. And a real big misconception is that every team member or every person cares for me because we have EMRs, because we have digital information. If I go to the emergency department, my providers are going to know about it. Most of those are either not true or not true in certain instances. So those are things that we're going to have to bring our patients in and make sure we're educating them on. Patients may not realize that just the same way there's that kind of lack of communication, that can result in a gap in information. You're potentially going to get those unnecessary tests. You have a greater chance for an admission. Now, an admission might be necessary. That observation stay might be necessary. But if it's not, you're potentially exposing yourself to other illnesses or other sick people that it's always nice to try and stay out of. I always feel like an emergency department visit is stressful for the patient, but it can be even more stressful for the patient's family. If I know that my dad goes to the emergency department, I'm going to be nervous about that because I perceive the emergency department as being a really significant illness or a really significant event. The same with when my wife's grandma goes to the emergency department. It's a big deal to me. So it's extra stress that we don't need to add to our patients' family members' lives. It's not always a cheaper option, and sometimes we think that an emergency department is going to be staffed only by physicians. That's not necessarily true. You're going to have a number of nurse practitioners and PAs staffing an emergency department, which can make it very similar to that walk-in clinic or that urgent care clinic. Now, that's not to say that all emergency department visits or cases are bad. Certainly, if a patient is in a kind of scary or potentially life-threatening situation where they're having chest pain, coughing up blood, severe burns, sudden blurred vision, seizures, high fevers, absolutely go to the emergency department. Those high acuity, truly emergent situations, the emergency department is great for those. Not every instance kind of falls into that category, but we do want to make sure that a patient doesn't disregard the fact that this might be the right place for some instances of care. So knowing that those are kind of great reasons to go to the emergency department, what are the reasons why our patients with UPQC went to the emergency department? By far and away, the top two reasons were diabetes without complications and primary hypertension. Now, hypertension, I feel like, is one of those that we can sort of wrap our head around and say, yes, that makes sense. It's probably that a patient's having some level of chest pain, anxiety, nervousness that caused them to be worried about their heart. But knowing that the number one reason why patients associated with UPQC went into ED was diabetes without complications, that's one of those that just kind of makes me scratch my head. Knowing that the number 4 reason was nicotine dependence. Those are things that I feel like we can, as much as possible, really try and redirect or provide care for in the clinic. So we're having those ED visits that have kind of inconsistent diagnoses or things that we feel like we can manage. So that provides an opportunity to, if we start looking at lists of patients that have gone to the ED a number of times, or patients that have just gone for any of these reasons that don't quite make sense, how can we more proactively reach out to these patients to help them? And, you know, what I would often kind of say is, that's a diagnosis. So the idea of how can we help them? How can we help them knowing a diagnosis versus how can we help them knowing a little bit more? Having a patient that goes to the emergency department and receiving a diagnosis of diabetes without major complications or without complications, that's kind of a number, that's a description. That may not be the why. That may not be why the patient went to the emergency department. So I think, as I'm thinking about the diagnosis, yes, it's valuable. I would say it's very directionally beneficial. It kind of points us to where we sort of need to start looking, but it doesn't get at the real reason. So a patient might have went to the emergency department because they were feeling lightheaded, because they were having maybe shortness of breath, because they were having just kind of an upset stomach feeling that just came on suddenly. Those are physical feelings. Those are emotional feelings, that nervousness. Maybe they don't know the best place to go for their care. Those are kind of the symptoms, the reasons for the visit. So one of the most important things, yes, is the diagnosis, because that helps us to kind of look at what the doctor ended up with or what the care team ended up with. But we can sort of work our way back to understand what the patient's logic was, why the patient went there. Understanding those symptoms, those reasons, that's where we can have a huge impact on our patients. And really one of the best ways to get that is to proactively reach out to our patient as soon as we find out about an emergency department visit. Proactively reach out to those patients that seem like they're using care differently than their peers, or differently than I guess we would have kind of thought or assumed. So in our last webinar, we did examples of Nervous Nellie, Sugary Stan, and Chatty Cathy. Now, all 3 of these had received care differently than we would have expected. Now, Miss Nervous Nellie, she struggled with her anxiety. And one of the things we started to do with Nervous Nellie, and the names are changed, but all 3 of these are true examples from another ACO that I work with. So Miss Nervous Nellie, she needed somebody to reach out to her a little bit more often, because she was just kind of feeling like, I'm not sure what's going on, so she needed a little extra help. This is a group that enrolled her in chronic care management. Sugary Stan did not do a good job controlling his diabetes, had multiple admissions, multiple ED visits, and they started setting up Stan with a regular A1C check. So while initially we think about patients going to the emergency department and it's a gut reaction can be, well, they provide coverage in hours that we don't, or they have more capacity than we do. Now we know that a pretty high number of ED visits actually occur during the day. A number of ED visits occur when we're open. So those are opportunities for us to educate the patient on why they need to come in and see us in the clinic, or how we can provide care alternatives to that patient to help them out, maybe like a chronic care management. Again, chronic care management might be right for some, it isn't necessarily perfect for everyone. But we do know that the right thing for the patient might be different for every patient. So as we're thinking about identifying those high-risk patients, that list is a what. And what's important then is, how do we take that list of patients, the list of symptoms, conditions, reasons why somebody did something, and then turn it into a why? Because each patient has a unique why, and if we can understand that, we can have a better impact on being able to reduce some of those admissions, reduce that unnecessary utilization, and hopefully help the patient to be as happy and thrive independently as possible. And when I say thrive, I mean, just imagine for somebody that went to the ED 25 times in a year, and each time takes at least 4 hours. Now we've just given that patient 100 hours back. Think of all that awesome stuff you could do if you just gave somebody back 100 hours. So when we're thinking about next steps, really engaging our patients is the best thing we can do. I would say set up those initial those meetings with your patient. When you're meeting with the patient, you can use that as an opportunity to develop a care plan. And then when you're meeting with the patient, talking about, all right, what do we need to do to help you? Sometimes it's going to be obvious. Sometimes it's something like, you know what, we should bring you into the clinic a little bit more often to check your A1C level. Oh, by the way, Medicare pays for it to be done once a quarter, so let's set you up once every 3 months to get your A1C checked. Sometimes it might be something a little bit deeper, and we may need to dig into other community resources that might be available, and that's something that Brian can help with if we get to that point. Certainly, we want to make sure that you have the tools and support necessary to help your patients. When we're proactively contacting our patients, it could be a phone call. It could be something done by an office assistant. It could be done by a nurse. It could be even a mailing. And then there's that always thinking about chronic care management. I will tell you that when I think about proactively reaching out to patients, it is so much more effective to have it coming from the physician or the physician's team than from someone else. Even name dropping the physician makes a difference. This is Adam. I'm calling from Dr. Ogden's office. Dr. Ogden wanted me to give you a call because it seems like, there's probably a chance, or Dr. Ogden wanted you to come into the clinic for some extra education. Wanted to talk about your recent ED visits. And having it come from the physician, having it come from the provider's care team, sounds much better than, this is Adam. I'd like you to come in because it seems like you went to the ED a bunch of times. Let's talk about that. Now, when you bring that patient into the clinic, that's kind of that icebreaker. That's a chance to really make a difference with the patient. And if you can schedule those follow-up appointments, especially for those ambulatory sensitive conditions like the UTI, pneumonia, CHF, those are things that Medicare kind of punishes or counts against the ACO. So if we can avoid those as much as possible, because there may be things that we felt like could be handled outside of a true inpatient setting, that's almost like a win-win, because we're helping the patient and we're also helping the ACO's quality score. When you're able to bring that patient into the clinic, that's a chance to review what happened, because the why is more important than the what. So we can look at the discharge note, we can read the final diagnosis from the provider, but we need to understand what caused the patient to go there, why they felt like this was the most appropriate care setting. Maybe it was, but maybe there's an opportunity to find alternatives or different care settings that might be an even more appropriate setting. So we can talk to the patient about what other tactics we could deploy. You know, if you feel like this again, we're going to fit you in first thing in the morning. Or if you feel like this again, once you go here, have your blood pressure checked. Go to Walmart. They have the blood pressure cuff. Get your blood pressure checked. Give me a call then. If you're a clinic that has an after-hours number, try that. If it's a patient that you think might be a good fit for chronic care management, that could be an opportunity as well. Again, chronic care management is that opportunity to extend the role of the clinic to the patient by phone. Now, if interested, we have a group that we partner with called ChartSpan. ChartSpan is a group that essentially all they do is provide CCM services. And Imperium does not get a cut of the money or anything, but Imperium, knowing that a number of our clinics are a little bit smaller, want to offer CCM but are not able to do it on their own, Imperium kind of negotiated a more favorable rate for the practices on their behalf. I would always recommend follow-up appointments as much as possible. So if you're having those patients that kept going to the ED, maybe pick a time every month, every 3 months, every month, so that we can get that regular kind of cadence of reviewing information. Sometimes urgent care is an option. If it is, great. I know for me personally, when I was doing something the other day and I got a giant sliver up underneath my fingernail. So I had to go online and try and find an urgent care. Not everyone thinks that way. And sometimes we don't think that way because urgent care is not really something that we have in our community. If your clinic does not have an urgent care available, or a trusted urgent care partner, you can always think about, is it possible to extend our hours? Maybe after meeting with the patients, it seems like, we're having a lot of ED visits that happen Friday at 3 o'clock. Well, we close Friday at 1. could we stay open for just a little bit longer? If it's option, or if it's available, maybe consider adding additional mid-levels to your practice, or kind of having one of the groups at an additional mid-level and referring kind of overflow patients to them. Using CareDirect to identify those lists of patients that are regularly receiving an ED visit will allow us to more proactively manage that list. And things like offering lab or imaging can help, or even IV fluids can help to reduce instances of dehydration, or help our patients to better manage their diabetes. Even that small A1C test that we could even do as a send out to like a LabCorp, that could be an opportunity to really promote kind of wellness activities and managing things at a local level, managing those clinic visits through, or managing the chronic conditions or the symptoms through lab work, as opposed to kind of letting it spike and get out of control and not doing some of the maintenance that we probably should. Any questions so far? I know that was a dense topic, and I kind of rushed through it in about a half hour, covered the material in about a half hour. Okay. As a reminder for the group, and if you don't have access or not maybe as familiar with CareDirect, reach out to Brian. I know Brian spent quite a bit of time navigating and helping others with CareDirect, but CareDirect is going to be similar to ACO Health Solutions, but probably a little bit more focused on actionable lists and a little bit less around quality documentation. So within CareDirect, you're going to look for the folders as much as possible, and those folders are going to how you're able to expand and view additional information. Now, when you're in CareDirect and just kind of navigating for yourself, you can select which provider, which practice, but I think most importantly, you have the ability to export those lists for yourself. So you can kind of toggle and make sure that you have the correct information, but you have the ability to export it as a CSV, which is essentially an Excel, or export it as a PDF. Those abilities to export the information will allow you to more kind of actively use the information. That way you don't feel like you're chained to it. And when you go to export, look for that blue bar in the middle of the screen, and then when the download pops up, click download so that you can use it for yourself. A couple kind of reminder nuances for CareDirect. Only living patients that are choosing to share data are available within ACO Health Solutions. The ED list, which we've just talked about, is going to show only ED visits from the last 12 months. So if you ever see a count that looks a little funky, or maybe a count from Brian or a count from myself looks a little different, we might be using more information than just those 12 months. There's also a SNF report, a really useful wellness visit report, an inpatient admissions report, and a home health report, which I personally love because it seemed like we spent a significant amount of time providing home health lists to practices so that they could more proactively manage their home health panels. And this allows them to kind of at their fingertips access that information for themselves. So kind of what's next, or key information. Brian's going to be working with you to provide some high utilizing patient lists so that you'll be able to kind of get that starting point, as well as offering any additional information related to CareDirect or password help. And I would just kind of use those initial lists as a way to start to identify resources, working with patients to really learn that why. Because the what is the list, the what is the name of the patient, the what is maybe the diagnosis, but the why is why the patient went, and how we can best help the patient going forward. And if you're interested in that additional CCM company, again, Imperium does not financially benefit in any way from this. It's just a vendor that's able to do something similar to what a lot of our practices have tried to do, and there are a number of vendors in the chronic care management space, so this was the one that we had sort of identified after vetting them and said that they're able to kind of do the best job. So those would be the next steps of Brian's going to work with you on some lists, make sure that then you have the tools to be able to start to have those why conversations with your practices or with your patients, and Brian will make sure that you're able to get to those lists going forward. The next upcoming webinar that we have is September 11th and 13th. We're going to talk about understanding post-acute care. Post-acute care is what happens to the patient when they leave the hospital. That was what I had prepared for the group today. Thank you very much for your time. I will pause now for any questions that you may have for me.